So per a wise commenter on Instagram, my social media, in regards to the recent COVID-19 posting of autopsy, the person had asked if I can post the video of some of the organs. So before I get started, I wanted to show you the sample tissue that I will be demonstrating via video. These first slides here, this is all lung tissue. This is heart. Some of the heart tissue has the thrombus in them. And this is still heart tissue. And here is a blood vessel in the heart. There's the other blood vessel in the heart. I think this one. And there is some more heart tissue, and that's more heart tissue. This is liver tissue, spleen, and pancreas. So, and the kidney sections are on the other slides, but I just wanted to kind of give you the gross of the sections of tissue that I will be showing you. Okay, and then we're going to begin to do the histology. So I wanted to begin by doing a scanning view of one of the lung sections. So I just want to peruse around first so you can see the overall gestalt, and it's going to go in and out of focus as I peruse around. But I want you to look at the overall image of the lung tissue. And that's the bronchialization that I was talking about, but we're going to go down further to show you what we're seeing. I just want to peruse around just to show you just how much damage this lung is demonstrating here through COVID-19. This is a pleural surface here. So most of the destruction of the lung is actually within the lung parenchyma. It's not on the outside of the lung. This will be the outside of the lung attached to the chest wall here. So we're just going to keep on showing you, perusing around at this power. And you can see the extensive inflammation here, but we'll go down. So some lung tissue is damaged more than others. Like this is not as bad, but as we continue to go around, you can see now some of this is collapsed. Remind you, some of this is collapsed lung tissue, but you can see more bronchialization, even squamatization of some of the epithelial cells, because you would think that this took place over a long period of time. You don't see that much the development of metaplastic epithelium over such a short span unless there is an induction of epithelial growth or some sort of, epithelial new growth in a sense. But, some of this is not bad. So I wanted to kind of show you, this was almost be resemblance of what normal lung tissue will look like. But I want to keep on scanning around just to kind of give you more picture of just how damaged this lung is. And then we'll go down to highlight some of the more specifics. Okay, let me just keep on perusing around. You can see no way one can breathe through this. And look at the scarring. Notice the scarring around the blood vessels. And around, look at this, almost like an amyloidal sort of scarring. I don't think this is amyloid, but that's just the intense degree of fibrosis because of all of the proliferation that is induced by cytokine, the inflammatory response, I believe. But we're going to go down even closer. Now it's going to go in and out of focus like I've explained before. Okay, here's another pleural surface here. So the pleural part, we can't call this restrictive lung because restrictive lung disease, you see more. Well, you can have a component of restrictive, even if the pleural, probably was a vessel actually, even if the pleurals, and this is almost I'm going to go down just to kind of give you a comparison of what normal lung tissue would almost look like. Okay, and even this is abnormal. You see, look at the fibrosis around the alveolar channels. So, okay. And now, so without prolonging the inevitable, let me just go down and show you the specifics. And as I hit on them, here's a blood vessel. Look at the scarring tissue around that blood vessel there. I think that's a blood vessel. Yeah, that's a blood vessel probably. Well, we know that. So when you see red blood cells in the lumen, you know you're dealing with the vessel. So there's a vessel that's quite fibrotic. And look at even some of the smaller vessels are fibrotic. Let me go around some more. And I just want to start showing you the inflammatory components. And even some of these cells that you see that look hazy like, those are perhaps viral cytopathic cells infected with viruses. Okay, and here's some squamatization or bronchialization of alveolar channels. And you can see more inflammatory cells. You can see the acute cells and the lymphocytes as well as we continue to go through. And then this is more intense bronchialization. And you can see the scarring tissue around the proliferating bronchial cells. And those are mature. You see the cilia on the top. Those are mature bronchial cells, but they're metaplastic. And this took place. This epithelialization took place over a short period of time as we continue. Now, some of these are terminal bronchioles, but others are actually metaplastic bronchial cells expanding into alveolar channels or alveolar cells. We call that bronchialization of alveoli. So I want to keep on perusing around. You can see, look at the scarring, intense scarring. And remind you, this is over a short period of time, more inflammatory cells. Okay, that's still an area of bronchialization. Like I said, we're going to go in and out. So you can see some plasma cells there. You see some histiocytes, some foamy cells, and more. Let me see if I can just keep on perusing around a little faster. It seems like it's going in and out of focus more than I wanted to. But I think you can see the overall image here. And you can see remember we talked about before the smudge cells, some hyperchromatic cells. And let me see. Let's see. Let me go to a higher power, lower power, so we can get an idea just where we are. And then I'm going to go up and down as I get to areas that I want to highlight. And I'm spending a little more time on the lung sections because this is where the money is for COVID pathology. So we're going to keep on going around. But you can see now some of these are alveolar channels, which are showing the fibrosis in the septal wall there. So let me see. You can see that there's no way you can breathe through lung tissue that looks like this. It's extensive fibrosis here. And like I said, I'm trying to stay in focus. Actually, this part is not as bad as I thought it was going to be, but it's still intense. And look at, even some of the smaller blood vessels got fibrosis around them. Now, some of this is perhaps due to, you can see some multinucleated cells here. Some of these are viral infected cells. But some of this is also due to this person having it's a syncytial cell there, some fibrosis. Here, a little vascular proliferation here. So it was like a culture for cell growth and reaction. Now, let me see. Maybe if I go down, see if okay, that's. And those nice, beautiful plasma cells there. But I want to remind you that notice how nicely preserved the cells are. The body has been dead for over 4 months. And you can still see nice preservation. Oh, look at the scarring around that vessel there. Almost like amyloid, or like I keep saying that makes me want to wonder if there was some sort of amyloid component to some of this. And those type 2 pneumocytes sloughing off. And look at the scarring on the alveolar septi. Okay, thought I was going to be able to show more. I don't want to waste too much time. Okay, so I think I've shown you that this lung is indeed damaged. I wanted to. Okay. You see some plasma cells. These are all the cells that are involved in the immune response to the COVID infection. Now, some of these look like foamy cells. Those are probably cells with viral infestation. And some of these are just reactive foamy cells. But it's hard to say now. And I had a case before that I suggested that we could get electron microscopy to bring out the cells that are indeed infected by the viruses. Sometimes you don't have the classic viral cytopathic effect that you would see with HPV and and herpes and some of the other CMV, some of the other viral infection. Now, these cells that look like they got a little hazy look to it, I believe that those are going to be viral infected cells, or at least debris that histiocytes have taken up from damaged viral particles. But this was a fight. I think Donald Trump called it a weaponized, wartime. Yeah, it's showing that our cells are fighting this thing with all the energy or ambition that it has, fighting the virus, that is. Okay, so I'm going to go to the heart next to show you the thrombus. It's going to be a long video, so prepare. So here are sections of the heart with the mural thrombus. As you can see, the thrombus, which is this material here that's in between the muscle, is intimately adhered to the muscular wall. And I'm going to show you how I made this, what are the characteristics that make this a thrombus. But right now, just this thing gonna go in and out of focus. Maybe I don't need to adjust my fine focus. But let me just continue to peruse around as I show you the characteristics that make this a thrombus. Again, it's going to go in and out of focus. Okay, there we go. Okay, so you can start seeing now we're in the heart of the thrombus. You start seeing some vascular channels here. Some of these spaces here, that's blood vessels within the thrombus. This is all thrombus. And I'm going to show you the organization of this thrombus here. It's called lines of Zahn, if I can keep on going around. So you can begin to see the lines. If you imagine, you got the inflammatory component, the blood component, the vascular component, and then the fibrous component. But anyway, this may not be a good section to show that. But this is not postmortem clot. This is an organized clot. Let me see if I can keep on going around. This is all the thrombus here. One of the sections of the thrombus. And again, going over towards its attachment to the myocardial tissue. And that's a little abscess there within the thrombus itself. All right. So, all right. Let me see if I can go to another section. Maybe we'll see a better section of the thrombus. So I was able to find a better section of the thrombus. Again, here's where the origin of the thrombus would be. You see the blood, you see the inflammatory component, and as we go up, this is called the lines of Zahn. So the blood, red blood cells, the inflammatory component, more vascular and fibrin mixture here. And as we continue to go up, then you can see the heart fibrin clot there. And see more. So that's the classic definition of a thrombus here. So inflammatory mixed with blood, vessels and fibrin mixture, and then more hard fibrin. Okay, and I'm going to show you that this too was adhered to the wall. Let me see if I can go. Just bear with me. This was a huge thrombus. Now I'm sure okay, maybe it's in here, not there. Let me go over. We're going to find it. Okay, this may have been just all thrombus, but I thought I was trying to take it. Let me see. Take it in relationship to its attachment to the muscle, but this was all thrombus here. Okay. So now we're looking at sections of the liver. You can see some zonal necrosis. You see some micro abscess. That's the classic abscess right there. See if I can go down even closer. Okay, where did that abscess go? Right in here. See the abscess, those are polys mixed with the hepatocytes. And then there's some zonal necrosis there. You see the necrotic hepatocytes. You see some viable hepatocytes there, and necrotic ones there with the inflammatory component to it. And here's a portal triad showing some inflammation, but if we keep on going around, you see that there was more inflammation within the triads. Some microsteatosis there. That's where you see the little fatty vesicles, fatty change there. But it's not, well, let me just keep on going on and see some more microsteatosis. And I interpret that as related perhaps to the medication that was used to treating. So it's not terrible, but there is some, I just crossed over one area that shows more obvious microsteatosis. But the liver, you can see, showing the zonal necrosis. I take it perhaps from vascular stasis. Remember, it was a huge thrombus in that right side of the heart. But there's some more little microsteatosis there. But there's definitely some abscess as to suggest that there was some sepsis, a septic component as well, infection. See more necrosis. There's a little slight fibrosis in the portal triad there, but there is no bridging fibrosis or cirrhosis. Just want to give you, and there is more intense inflammation within one of the portal triads. And obviously some zonal necrosis. There's more little micro abscesses within the hepatic lobule. So I think you get the overall picture of this liver showing the same thing. There are some more micro abscesses, perhaps from sepsis or even dying liver cells. And there are some more microsteatosis, which I interpret again related to medication use. Okay, I think we see the overall gestalt of the liver. So we're going to go next to, not going to show the spleen, but I will show the kidneys. So we're looking at the kidneys now. You can see the glomeruli and the tubule. The tubule showed extensive acute tubular necrosis. But let's go down and look at some of the glomeruli up close, if I can get it in focus here. Alrighty. So there's a glomeruli, a very damaged glomeruli there. There's one that's showing some mesangial cell hyperplasia, and this person was hypertensive, but the kidneys are definitely, you can see some little proteinaceous debris within the kidneys. I think she did have some diabetic component as well. As I keep on going around, I wanted to show you some of that's not a bad glomeruli, but you can see that the mesangial cells are definitely increased. I wanted to show you, maybe it's hard to see, but I think some of these glomeruli actually had clots in them. I mean, look at that right there, proteinaceous stuff around the tubule here. Dead tubules there. What is that? Now I know I was close to a glomeruli. Here it is. Now I think I interpreted some of this change here. That's not bad still. There were actually some clots. I know it's going to be hard for me to show some microthrombi within some of these glomeruli. And well, I don't see it there. Let me just go back to a scanning view and see if we can see it from there. Perhaps we will find some as I go around. But you can see that this kidney was taking a beating. I don't see it now. But believe you me, there were some microthrombi in some of the glomeruli. Well, it's not that bad. Maybe here's one here. Still not that bad. Not that bad. I think that's one that I just showed, so not that. Let me just go around. It may not be in this slide, but in one of the slides, it was quite obvious microthrombi, but I mean, I'm sure it was. I mean, the person had obviously DIC. So some of the small vessels indeed had clots in them. All right, so now we're in the collecting tubule part of it. So that won't, okay, there are some more. I'm sorry, we're going in and out of focus, but that's the nature of being a pathologist. We obviously use our fine adjuster quite a bit. And so if you're seasick, you couldn't be a pathologist because we obviously go in and out of focus quite a bit as we examine all components. This is all renal collecting tubules. But anyway, you can see some clotting there, but this isn't probably not. Let me see. I just want to convince to you that I indeed saw some clots. Let me go to another slide. Okay, we're beginning to get to them now. I'm going to, without wasting a lot of time, I'm going to go right to the money of what I want to show you here. So you see these glomeruli now. Now you see they're dilated, and some of those capillaries are actually showing microthrombi. You can see the inflammatory dusty material around it. But those are microthrombi. Those are fibrin clot within glomerular channels. I mean vascular. And one could think that they're just a stasis of blood, but I don't, as I can show you the overall gestalt of some of the other areas. That's real. And so anyway, look at that right there. That's real. There's some clotting, microclotting in some of the glomerular channel. That's real. Okay. All right. There are some more. All right. All right. So that concludes this presentation.